See my slides?
We can see your slides. If you can just give me a minute, let me introduce you and then we can.
Sure. No, I'm just.
Yeah, it's perfect. It's perfect.
Sure.
It's
Thank
absolutely
you.
perfect. Hi, good morning, everyone. Welcome to 142nd episode or session of CMAAO International Weekly Meeting. COVID cases are increasing everywhere in the world. So we are not sure what's going on. We will have a session on COVID, especially next week or probably next to next week, discussing about what's going on. But today we are talking about impact of obesity on gynecology, a session number 142 from CMAAO. And to talk about this topic, we have Dr. Sujit. He's an MBBS diploma of National Board of Obesity and Gynecology, Fellowship in Minimum Access Surgery, World Association of Laparoscopy Surgeon, Diploma in Gynecology, Gynecological Endoscopy from Kehl University, German, IRCAD, France, Senior Consultant in Gynecology and Obesity, Department of PD, Hinduja Hospital in Mumbai. We welcome you, sir, on this forum. This is a National Association Forum for doctors, and the session is on live on Facebook, YouTube, and all other channels. So there's doctors in this forum, and there will be public who's watching on the regular Facebook channel. Over to you, sir.
Thank you, Saurabh, and good morning from India to everyone who's gathered in here. Thank you for the warm introduction. So I'm Dr. Sujit. Just one thing, I'm a gynecologist and obstetrician and not obesity department. So just a clarification on that basis. Today, we'll be talking about the impact of obesity in obstetrics and gynecology. Before we go into OBGY in general, let me discuss about some other things. So Walter de la Mare, he is an English poet, he had said, "Oh, pity the poor glutton whose troubles all begin in struggling on and on to turn what's out into what's in." With that, I just give you a brief about what's happening in the world. World Obesity Foundation 2023 had a report. This collaborated a lot of details over the world, of which it said that WHO says worldwide there are more than 1 billion people who have obesity. Of that, when you take into the breakdown of the statistics, 650 million are adults, 340 million are adolescents, and 39 million are children. Of this, 51% of the world, or that is around 4 billion people, are actually into the category of obesity or overweight, will be seen over the next 12 years. And the important concern is childhood obesity could more than double from 2020, that is from 208 million boys and 175 million girls by 2035. That's a huge risk that we'll be facing over the next few years that is coming. In 2020, 2.6 billion people fell into obesity, or that is around 38% of the world's population. And what we see is that the rate of obesity are rising particularly quickly in children and in lower income countries. That is what was noted by this report. And as we were all discussing before the talk started, during the COVID-19 pandemic and what we are seeing around, there's a huge rise in the obesity over the last few years, and it is bound to rise because of the lifestyle changes that is happening, since most of us are working from home or are limiting our lifestyle. Morgan Spurlock had once said, "I couldn't open up a magazine. You could not read a newspaper. You could not even turn on a TV without hearing about the obesity epidemic in America." Frankly, it's more than an epidemic. It's a pandemic which is spreading rapidly. So what's the scenario around? So CDC states that obesity currently affects 4 out of 10 Americans. A little bit of American statistic before I jump into India. The AHA says that obesity is linked to 30 to 53% of new diabetes cases in US every year. Again, WHO says that 4 million people die each year as a result of obesity. And the World Obesity Federation has noted that 1 in 5 and 1 in 7 men have obesity by 2023. All these things, the weight and the overall health of the person are interconnected, because we all know about the non-communicable disease that can rise because of obesity, which can include your type 2 diabetes and certain forms of cancers, and obviously the heart disease. And what this does, it adds a burden to the medical cost of the person, because they'll require more time for admissions. The treatment takes a longer time. And when you look at the productivity, they lose around 3 days more compared to an average person in a year because of their productivity. John Galbraith had once said, more die in US because of too much food than too little food. So we've seen all about the US, now coming to the Indian scenario. So India ranks 3rd in the world when it comes to obesity after US and China. As per the NFHS, that is the National Family Health Survey 5, Indians are getting fatter, and that is the big problem. We have long been known as a third world country where you see malnourished people, underweight people. But as you're seeing, as we are talking, as this goes on, you'll realize that we have broken into the top 5 countries in terms of obesity in the last few years. About 6.4% of women and 4% of men aged in 15 to 49 are obese. And this is the working age group. And that is why this becomes a concern whenever you think about the development of a nation. This is a small chart which I had found, which states that how it's increasing over the higher levels of income group also. So just a brief idea that we were discussing, that we are a third world country and the poorest people, they are not malnourished. We are seeing obesity affecting a lot of the good doing people and the high class people. So as you
I
see,
think your slides are not visible.
this one, everyone can't see the slide?
No.
Yeah.
This one?
No,
Nope.
we are not
We have
looking
not
here.
been able to see your slides since the beginning.
Okay, just give me a second. I'm very sorry. Can you see it now?
Yes, no.
Okay, fine.
Can you make it on a presentation? Yeah, okay.
Yeah, are we okay? Just
Good.
a second. Just give me a second. I'll move the things. Sorry. So this is what we were discussing before we had a glitch. So obesity prevalence is seen more in the higher income age groups. What we expect that the higher income would be more aware and they are reading a lot, but then surprisingly, this is a drawback which we are seeing. They just accept their lifestyle as it is, and there's a rise in the weight. Pradeep Chaubey, Dr. Pradeep Chaubey, the former president of IFSO, had said, every 10 kg of extra weight reduces your life by 3 kgs. So if a person is obese by around 50 kg, they end up losing 15 years of their life. And again, like our discussion was happening, we also saw that the mortality during COVID was 3 times higher for obesity and overweight patients. This is a rough idea of how we see that there's an increase in overweight Indians over the last few years. And it's rapidly growing under the middle-aged age group among the Indian society, as which is evident from the NFHS 3, 4, and 5. So now let me begin with what I am doing here. So the journey of womanhood, I always begin with this thing. The journey of womanhood is a very complicated one, but that's something which is very beautiful. For wherever, see, a woman goes on from childhood, adolescence, reproductive age group, perimenopause, and menopause. And for a woman, that's the most beautiful thing because she has a change. Unless like a man who has a linear life growth, which happens. For women, every scenario, every journey presents with a challenge. And that is why we have to tackle it at all different scenarios that we go through. So why this discussion? Women are slightly more likely than men to have obesity. And this bound to have an impact on the female reproductive health. There's a nice hypothesis, which is the Barkan's hypothesis, which states that because of any fetal issue, there is a thing which happens for the adult also. As you're in utero, and if there are changes which are happening, that will affect your later life. So it becomes important that you start managing directly from the mother so that the baby is not affected and that baby doesn't grow into something which leads to complications for his or her life. Over the discussion, we'll be seeing all these things. Childhood obesity will affect your early onset of puberty. It leads to menstrual irregularities when you're adolescent, and it will lead to PCOS. Reproductive age group with high BMI will lead to, again, higher risk of ovulatory problems, and they'll be poor responders to any fertility treatment. And we have aggravated symptoms of pelvic organ prolapse, SUIs, which will be noted. Also, there's an increased risk of endometrial polyps and some cancers and symptomatic fibroids. All these things will be touched in the next few slides. Sustained and substantial weight loss is difficult to achieve, but with lifestyle changes and dietary measures, this is a possibility. Also, there is a lot of pharmacological treatment that are available. And with the data that we have, we can bring about a change for women, and also with the bariatric surgery, which is currently done quite significantly without a lot of complications, that also form the stay of treatment. Swami Vivekananda had once said, there is a chance for the welfare of the world only when the condition of women improves. It is not possibility for a bird to fly on only one wing. So why me? Well, as a gynecologist, I probably have the best job in the world. I meet women at all different scenarios of their life, and that is when I can address to each of them at different stages. No other medical specialty comes so close into forging a lifelong relationship and the interdependence with the patients as does me or any gynecologist out there. And again, we care for women throughout their lives. So that's why me. So coming to whatever we'll be dealing with at different scenarios. So puberty, what do we see? So there's a critical weight hypothesis, which states that once you reach there, menstruation is established only when the threshold weight is above 48 or 70% of the body fat composition is achieved. If the baby or if the young girl is on the higher side, on the heavier side, then there is accelerated aromatization of adrenals and ovarian androgens in the adipose tissue, that's the fat content, which increases the bioavailability of the sex steroids, and this promotes early androarche, pubarche, and thelarche. So this is why they have an effect where they attain precocious puberty. Girls with an early onset of puberty are again at a high risk of ovarian hyperandrogenism and PCOS, as well as in later stages, they might land up with cardiovascular issues. Moving on to the reproductive age group, subfertility and anovulatory, which is one thing which you'll come across in such kinds of patients. There is an increase in leptin, the hormone which is there, and decrease in adiponectin levels in the circulation. There's a balance which needs to be maintained between leptin and adiponectin. Leptin has a stimulatory effect on the hypothalamo-pituitary axis. This will inhibit your ovulation for the ovarian folliculogenesis, as well as the LH and the insulin-mediated steroid production by the granulosa cells and the theca cells. So in general, your leptin is messing up with your entire HPO axis, and that will lead to subfertility. Obesity-related hyperinsulinemia, that everyone is aware about, but this will also cause hyperandrogenemia from the granulosa cell apoptosis. The peripheral conversion of androgens to estrogen in adipose tissue also will affect your gonadotropin secretion, that's at the hypothalamus and the pituitary level. And approximately 30 to 75% of women with PCOS are obese with central obesity, which is noted in 50 to 60% of women with PCOS, irrespective of BMI. So now it has to be managed. Ovulatory problems, they are poor responders to ovulation induction also. So even if you're trying to stimulate a patient for getting ovulation, that also will be affected. A systemic review was done with 13 studies, which identified that obesity and insulin resistance as predictors of treatment failure following your even gonadotropin treatment. So obesity is positively correlated with gonadotropin dose and cycle cancellation, and negatively correlated with ovulation. So your ovulation treatment and induction, that also can land up into failures. A multicentric study was done investigating 335 women with anovulation that showed that despite the requirement of higher doses of gonadotropin, with producing fewer follicles, women with high BMI achieved similar rates of ovulation and clinical pregnancy as compared to their lower BMI counterparts. This is one thing which is a contradictory thing. But when you see another study, which was a systemic review of studies which was done, women with BMI greater than or equal to 25 have lower pregnancy rates, require higher dose of gonadotropin, and have a higher rate of miscarriage. This is what we see basically in our clinical practice. Now they have become pregnant, so what the complication that we face, they'll end up with high early pregnancy losses. A recent systematic review showed that women with greater BMI, which is more than 25 or so, have significantly higher incidences of miscarriage regardless of any method of conception they have achieved. Overweight women are more likely to miscarry after ovulation induction as the high BMI recipients of donated oocytes also. So it's not just her eggs which are leading to issues, but it's donor oocytes also. So eventually the problem lands up with the woman and her hormonal issues. Obesity impacts the ovarian environment, and that is what can be regarded as what leads to impaired folliculogenesis and oogenesis. An alternative view is that obesity can have detrimental effect on the uterus also. It leads to certain changes in the uterine environment, which have been shown by certain studies, where the adjustment of the embryo quality is good, but then you have certain cases because of the lining of the uterus, and that can lead to high issues of miscarriage. Now, what happens in the entire pregnancy if the patient is obese? Then patients feel uncomfortable and have dyspnea on exertion. There are medical complications, which can be seen as hypertension or the GDM, that is gestational diabetes mellitus. There's difficult diagnosis and presentation of the baby or noting the FHS of the baby. Obviously, there's fetal macrosomia. As a doctor, when you want to look after all these things, there's increased ANC, the antenatal checkups, and the ultrasounds which we ask for. Obviously, there's increased risk of miscarriages, fetal malformations, and especially neural tube defects. There can be issues of post-maturity or IUFD or stillbirths. And such women also land up with increased chances of candidiasis or UTIs, and all these infections can lead to preterm labor. In effects of labor, we have increased incidences of labor dystocia or prolonged labor. There might be increased operative interference, and the patient might land up with C-section. During vaginal delivery, the patient can have shoulder dystocia. If you're doing a cesarean or any other thing or any other operative procedure, this patient might land up with anesthesia hazards like difficult intubation. And after delivery, such patients can have puerperal UTIs. They are at a higher risk of getting postpartum hemorrhage. They might land up with DVTs. If there's a cesarean or any episiotomy, there might be poor wound healing, which might be there, or she can land up with lactational failure. So there was this report which was there by the CMAAO, which stated that overall half of the maternal deaths which were reported occurred in women who were overweight or obese. So what you need to know is that obesity in pregnancy is a high risk. This required adequate ANC and hospital delivery, which is mandatory. When you look into the weight gain in pregnancy for such women, obese women should have a limit in weight gain, which is less than 8 kgs. Surprisingly, when we had a statistic, so I was working with a professor and we were doing this over the last 10 years that he has kept a track. During obesity, like during obese and pregnancy, we have statistics where we don't even allow the patient to gain 1 kg of weight. In fact, we encourage losing weight during pregnancy because that's the best time where the patient can work on a weight too. And early mobilization and heparin prophylaxis is given to prevent DVT. It's also challenging when you think about contraception for such ladies after delivery. Oral pills are best avoided. Intrauterine device can be considered. This is something which can be done for women. Also, you can consider tubal ligation, though the studies say that mini lap or laparotomy is something which is preferred. Lap TL also is fine if you have a good anesthesia setup. So coming to the major contraception part, in a large cross-sectional study that was done, it was seen that obesity was significantly associated with contraceptive non-use. And this was because of the perception that obese women have lower fertility, or these women were in general worried that if they take any hormonal contraception, they might land up with, again, increased weight gain. This is just a myth which is being carried on, but we have a lot of things which we can do for this woman. There's a little evidence which suggests the link of weight gain either to OCPs or LNG-IUS, that is the Mirena, or just the progesterone-only pill. Studies suggest that whatever we were discussing this, medroxyprogesterone acetate can lead to substantial weight gain, which was seen, but not with correlation to LNG-IUS or progesterone-only pills. In an analysis of data which was done for women with body weight more than 70.5 kg or so, they had an increased contraceptive failure as compared to women who had weight less. But by comparison of women with less BMI, the risk of pregnancy was higher in women with high BMI and still higher in women with high BMI, which was more than 32.2. Again, a study which was done, which showed that the doubling time taken by levonorgestrel to reach a window of opportunity, that was altered. Therefore, there was follicular recruitment, development, and ovulation, which was affected, and that was what led to even contraceptive failure. In addition, the combination of use of OC pills is actually not without any hazard if you actually take a proper history of the patient, ruling out migraine, blood pressure, and venous thrombosis history for such patients. And we continue to use OC pills also in obesity. In a multicentric trial that was done in China, found that the dose-response relationship between weight and failure rates was higher associated with Norplant. That's one of the other contraception that we are using. The results of secondary analysis of efficacy studies have suggested that contraceptive failure associated with the transdermal patch, which is available, was again higher with women with increased body weight. So Norplant and patches, as per studies, they are not shown to be effective for obese women. Now coming to the menopausal transition. In a longitudinal study that was done for menopausal women, subcutaneous and visceral fat deposit which happens were noted to increase during the menopausal transition. Obesity increases the peripheral conversion of androgens to estrogen. And this estrogen, circulating estrogen, will affect the woman over the later stages, and that can lead to endometrial hyperplasia and cancer. In a study of abnormal perimenopausal bleeding, obesity was shown to be independently associated with high menstrual bleeding. Whenever a patient comes to the perimenopausal or postmenopausal patient comes to you in the OPD, when you have a look at the endometrial thickness, any endometrial thickness of more than 4 millimeters is obviously something which raises the eyebrows. So what we have noted that 60 to 80% of this women, obese women, have higher endometrial thickness, and that leads to abnormal uterine bleeding or postmenopausal bleeding in such women. Also, there is something what we call as a corpus cancer syndrome, that is high BMI, obesity, diabetes. All these things tend to lead to higher incidences of endometrial cancer for a woman. So this is just a gist of whatever we have seen over the discussion that has happened. Moving on to specific gynec complaints that we can interact or that we can come across whenever a patient is obese. Obesity is associated with long and irregular cycles, obviously because of the conversion of the peripheral estrogen that happens in. Women with BMI of 35 have 5-fold higher increase of long cycles as compared to women with a normal BMI. A cross-sectional study that was done in Australia, aged between 26 to 36 women, they found that irregular cycles were more, that is 2.6 times higher in a woman with greater BMI as compared to a woman with a normal BMI, and with a woman with high waist circumference as compared to a woman with a waist circumference of less than 80. There was a study by Onalan et al. Which demonstrated that BMI greater than 30 were more likely to have endometrial polyps also, other than women with a lesser BMI. And obesity is again an independent predictor for development of endometrial polyps and positively correlated with the size and the multiplicity or the number of polyps which a woman can have in a uterus. Fibroids are labeled to be hyperestrogenic state, leading to excessive growth of the fibroids that can lead to issues overall depending upon where the fibroid is. In a retrospective study, it was seen that uterine fibroids were more likely to be seen in obese women than in general population. Another study, fibroids were associated with BMI greater than 25%, along with concurrent hypertension, occult obesity, and high upper body fat distribution. The risk of developing fibroids is tripled in women with body weight of 70 or more as compared to women in the weight group of less than 50 or so. They'll end up with urinary incontinence too. Increased waist circumference is associated with SUIs. Possibility this is because there's a rise in the intra-abdominal pressure caused because of central obesity, which is influenced also by the duration of the obesity which the woman is going through. A review which suggested that obesity and overweight increase the risk of urinary incontinence, especially the SUIs as compared to urge. There's a causal association which is seen in an RCT that was shown that a 6-month behavioral intervention targeting weight loss led to reduction in frequency of self-reported episodes of urinary incontinence. POP, that's pelvic organ prolapse. Again, it's high seen in morbidly obese women and considerably severely obese women as compared to a normal woman. WHI, that's Women Health Initiative study demonstrated that 55.7 women gained weight over a period of 5 years. These women showed to have exacerbation of prolapse, exacerbation of cystocele, rectocele was also noted in women who were even overweight and above the baseline of obesity. In overweight and obese women, worsening of symptoms of cystocele occurred in 32 and 48%. Similarly, rectocele was seen in 37 and 58%, and uterine prolapse was seen in 44 and 69% respectively. A small degree of weight loss was associated with borderline worsening of uterine prolapse. This was a surprising study that I came across, which said that even if you have a weight loss of around 10%, the uterine prolapse and the worsen with minimal regression of cystocele and rectocele, which said that once you're obese and the duration of obesity has been continued, this actually leads to a weakening of pelvic floor, and that is irreversible. Other studies have actually shown that surgically induced weight loss might be beneficial for pelvic floor disorders in morbidly obese women. When you come to surgeries in such patients, major gynecological surgeries always present as a high risk and as a challenging case for a surgeon. And the anesthetist. Anesthesia and morbidly obese is obviously difficult, and you need a proper setup. Luckily, where I work in, the anesthetists are very well trained to manage even morbidly obese women, because there might be challenges when you have to have a vascular access or peripheral or neuraxial blockade or intubation. And you have to remember that obese patients are more likely to require thromboprophylaxis, aspiration prophylaxis, and they might require a prolonged post-anesthetic care in high dependency units. When you consider which mode of surgery you have to consider, everything presents a challenge. So if you have to do, for example, just take for an example, if you want to do a hysterectomy, the approaches can be either abdominal or vaginal or laparoscopy. Abdominal presents such challenges like you might have higher blood loss because you're not in the proper plane, or there might be post-operative pyrexia because of infection which can happen, subcutaneous infection which can happen in the fat. This leads to increased hospital stay. And usually we do it in some patients also. You can do a panniculectomy in such patients if you're coming across a high pad of fat in the abdomen during the surgery. When you have to compare it with non-obese women, vaginal hysterectomy is also known to have a higher operating time and more blood loss as compared to in an obese woman as compared to a woman with non-obese. Obesity has obviously higher implications whenever you have to do a laparoscopy surgery, not just from the surgical point of view, from the anesthesia point of view, from the lung point of view. The lung volume decreases or the lung capacity is affected. The return to the blood return to the heart is affected. The entry ports are difficult. You have to think about proper placement of ports which have to be managed, not just the primary, but even the additional and the secondary ports that is there, which can be challenging because you might not find out the vascularity which is there and you can accidentally nick one of the blood vessels on the superficial level. And this might require a likelihood of conversion from laparoscopy to open surgery. Louise Newson, this lady I found on Instagram, she had said that the woman I was made me the woman I am. So I can't wait to meet the woman I become. So we have to start affecting or changing the woman she is so that she'll become a woman that she'll like over the years to come. So we have to think about the management. Moderate weight reduction of around 5 to 10% has shown to reduce the risk of comorbidities and encourage the resumption of ovulation in ovulatory women. So whenever a patient who comes to PCOS or irregular cycles who come to my OPD, I always tell them that at least try to reduce 5% of your weight. And this shouldn't be drastic. This can be over a period of like maybe 1 kg in a month or even 500 grams in a month. Don't ever underestimate or put a lot of challenges in front of the woman saying that, no, you have to lose a lot of weight dramatically. That itself will lead to depression. You have to consider the mental health of that woman who comes to you or the lady that comes to you. So always give her tasks or give her the markers, or you tell her that this is the target that you have to achieve over next few months, next few years. And that is how it will affect your thing. And once she starts losing it, she'll herself feel the changes, and then she goes on with it rather than you giving like, okay, no, you have to lose your weight within 1 month and that is what will help you. So it has to be targeted and it should be proper balanced. You have a lifestyle modification, you do diet changes, exercises are advised, all these things will help. Whenever advising exercises, make sure that you're targeting the not just the aerobic exercises, but always strength training that has to be advised, or certain bit of stretching or yoga that can be done, so that eventually the girl or the lady will be better over the years to come, even when she reaches menopause. In a recent study, which was there by APCOS, which concluded that lifestyle modification was paramount importance whenever you want to treat metabolic complications and to improve the ovulatory function. So what happens is basically whenever you have a weight loss, there's a biochemical impact and a clinical impact. In the biochemical impact, what you see is a reduction in visible adipose tissue. There's increased insulin sensitivity that will decrease the circulating insulin, and this will affect the leptin also. It improves the lipid profile, increase the sex hormone binding globulin levels, and this will decrease the free androgens, and eventually the reduced ovarian volume will become better. Clinical impact: resumption of spontaneous ovulation can happen. Spontaneous conception will take place. The woman has a regular menstrual cycle. The reduction in number of the urinary incontinence symptoms that can happen. And overall, obviously, we have to think of the long-term thing. So there's a reduced risk of comorbidities that can happen with obesity. Robin Williams, I guess everyone knows about this famous author. He had said that you treat a disease, you win to lose. You treat a person, I guarantee you, you will win no matter what's the outcome. So treat a lady, treat the person, not just the disease that you're coming across. There are a lot of pharmacological agents that are available, and nowadays, everything with tons of research and clinical trials that have been done, there are things which have been coming up which are more or less approved by a lot of doctors and all around societies. Drugs like orlistat, silbutyramine, the rimonabant, and metformin. Metformin is something which I love. This is something I call it like a wonder drug. Whatever I've used, this is something which I used in younger women, pregnant women, preconception, and even obese women. Yes, you have to regulate the dose and explain the patient whatever she needs to be taken care of. But metformin for me, this is one thing which I use quite commonly. If I have anything which has to be managed significantly, then obviously we have a team of doctors, like a physician, a bariatric doctor who the patient meets, the lady meets, and that is how it's a multidisciplinary approach that happens. And bariatric surgery, yes, this is something which is picking up nowadays. We almost have bariatric surgeries happening every month. And following bariatric surgeries, there have been improved in fertility. There have been improvement in the fertility statistics and reduced risk of obstetric complications also that we are noticing, such as GDM, macrosomia, and hypertensive disorders in pregnancy. Yes, bariatric surgeries come with its own complications also, but you have to explain to the patient the risk and the benefit ratio, and that is how it works out. Pregnancy should be avoided during rapid weight loss. This is something which I always tell that nothing should be rapid. It has to be gradual. So once you have the bariatric surgery, wait for a while, wait for at least 6 months, that your entire microbiome level and the micronutrient level that is corrected, the macronutrient level that is corrected, and then go for it. Because IUGR and nutritional deficiency during pregnancy are likely to happen when you have a surgery after, when you have a pregnancy immediately after a bariatric surgery. Michelle Obama said that communities and countries will ultimately benefit only as strong as the health of their women is. I'd like to end with that. Thank you so much. So this is something which I do. I do a podcast also on women's health and social issues. So there's one thing which I always say to all the ladies out there, or all the uterus owners out there. I'm speaking for the bisexual and the one who are not gender defined, that you matter, you are important, and you're heard, and we are there for you. Thank you.
Thank you, Dr. Sujit, for the wonderful talk. I would request you to kindly close the screen sharing.
Just a second.
Okay. I see a lot of chat discussions going on, and Dr. Monica, would you like to invite people for question answers over here and take questions?
Sure. I'd like to first say what a fantastic presentation. We all understand that obesity has multi-system effects, and the impact, especially in the OB and gynecological world, is something that we cannot ignore, and maintaining the women and their weight and to optimize all medical conditions while they're in the childbearing age is so important. And we appreciate you highlighting this. What I did do before, if there's any questions, I can take it, but I can also kind of review what I had been putting in the chat during your presentation, was that we are at the threshold of a dramatic shift in the approach to weight and weight loss in North America. In January, the American Association of Pediatrics came up with new and very aggressive guidelines in addressing obesity in children, stating that it is a disease. And I will read to you the comment that I had posted. The American Academy of Pediatrics has updated its guidelines and for evaluating and treating childhood obesity for the first time in 15 years. The new guidance reflects a major change in clinical perspective on obesity. It reframes obesity as a chronic disease rather than a result of personal choices, carrying significant short and long-term implications for children's health. It recommends early and intensive treatment, including medications and surgery for some young patients. The group is recommending nutrition and behavioral therapy for children under 13 and adding bariatric surgery for teens. Very aggressive. And then the second part of my chat, I was talking about patients. So for those who don't know, I treat asthma, allergy. I'm an asthma and immunology and allergy specialist. And a majority of my practice deals with obesity, and with asthma. And we all know that obesity, just like in your obstetrics and gynecological world and its outcomes, also has a dramatic impact on respiratory illnesses and asthma. And a lot of these patients that I see who have comorbidities such as sleep apnea, diabetes, the treatment of their asthma has been hindered by their comorbid conditions, have now been placed on Wegovy, which is a new weight loss medication that's injectable. And I have seen patients, at least since the fall, which have been, I think they've had weight gain during the pandemic, or they're just not been able to lose weight for whatever reason. And they are having dramatic weight loss with minimal side effects. This medication is currently available in the United States, in Canada, and the United Kingdom. And I think we need to keep our eyes and ears to the ground in terms of looking at what the long-term outcomes are of this medication. And I think it'll revolutionize these comorbids in all the specialties that we represent in our medical fields. And because its use in diabetes, it will also have implication in women potentially with PCOS and all the other endocrine comorbids with your specialty as well. So that's all that I wanted to add. I felt your presentation was fantastic. I think that we understand the role of obesity, but you were able to pull and kind of give us the finer nuances of your specialty and why even on a more pathophysiology level, why it's really important. So thank you for your presentation. Are there any questions from anybody?
Dr. Ravi, you're muted.
No, nothing from my side.
Dr. Angelique?
Morning, and again, I just would like to reiterate that what Monica just said. This was a very, very good presentation. I'm actually also very glad that you didn't focus on the fact that obesity is a eating problem disorder, because it's not always an eating problem disorder. There are multiple factors around this. So I'm always, if I, looking in my own country, it's always, or most of them, well, let me be not politically incorrect, but you will find that quite a huge percentage of our people living in poor conditions are overweight. It's not because they have money to buy all these luxury foods. It is because the food that they can afford is unfortunately adding to their weight gain, and not because they eat that much. Or so thank you so much for this, and Monica, thank you for that beautiful sites that you have put onto the screen. I think it's extremely important. I've already downloaded them so that I can go and read them. But thank you again so much. And yes, there's also a link between obesity, if I'm not mistaken, and breast cancer. And breast cancer is currently one of our biggest cancers especially in South Africa and the females. So again, thank you for this beautiful presentation. It's needed. Thanks.
Thank you so much. Are there any others who have any other comments or questions?
So either everyone has got everything, whatever I've spoken of, they have not got anything.
You can start quizzing us now.
No, but then nice. Thank you, Angelique. Thank you, Monica, for bringing up that point. So yeah, the drug that you mentioned, I was going through it, but then it's quite new. And like you told me that it's majorly focused on US, though I presented a lot of US statistics. I felt that something has to be like whatever I'm speaking eventually had to end from the Indian perspective, because this is what I see, this is what I manage. That drug currently has not reached India also, not even on the trial basis. So that is why I didn't touch on that point. Here, bariatric surgery is going rampantly. Like there are actually bariatric clinics that are being developed, or doctors just newly passed out, they are just doing their bariatric fellowships and getting onto that. And yes, the results are good, but then you have to understand the implications of a bariatric surgery that can happen to a woman also, or to any person, the malabsorption that happens and all those things. So that has to be stressed on. So whenever a patient comes to me post-bariatric, we have an entire panel of doctors that include like right from consulting. Whenever a patient comes just for the obstetric point of view, she meets a nutritionist, she meets a dentist, she meets a Lamaze class or a ANC yoga teacher, she meets the pediatrician, she meets the anesthetist. That is what the entire plan or the setup is. So it's like she has to be aware about whatever things she has to go through during that entire pregnancy, and we are there for her. That is how the setup works out here. So that even if there's something which needs to be done in the diet, first 3 months of the pregnancy, I tell them eat or drink whatever you want. Obviously not alcoholic, but then that's the time when the woman is not eating well also. And that is the time she thinks that, okay, I can't eat this or that. But once she's 3 months and once the hyperemesis settles in, the nutritionist kicks in, and then the diet is regulated so fantastically that, like I was telling in the presentation also, our women out here, they don't actually gain weight during pregnancy, the ones who are obese. We have had weight loss of 5 women who have lost 5 kg during pregnancy, the ones who are obese. So that is how strict the diet management and walking and all those things, the basic things, what you need, like rather than going into medication or drugs or the hi-fi stuff. I call them hi-fi stuff for my patient. Just focus on your diet, focus on your basic lifestyle, the exercises. And that is what the key is. Focus on the lifestyle, focus on your health, and understand the importance. And once you start showing them that this is the thing which is supposed to happen, and they see changes in the 3 months or 6 months, then they think that it's a magic thing that's happened, and then they follow. Rather than you forcing it onto them and then like, no, this has to be done, this has to be done. Just give them the opportunity and have patience with them. This is one thing important. Mental health is something which is drastically bad, or I don't know, bad is not the correct word, but it's drastically affected for such obese women. Like I speak of women specifically because that is whom I interact with. They are terrible because body shaming, that's one thing which happens to them. Apart from that, they feel very conscious wearing anything, doing any activities also. So when you sit with them, talk to them also on these things, like the doctors out here, whosoever, whichever specialty you're in. I speak a lot for women. That is what I do. That is why I'm again taking this as a platform. Like since we have so many eminent doctors, just spend time with them, talk to them, understanding their issues, understanding their problems. When any patient comes to you, and specifically when obese women come to you, listen to them. That itself will probably help them wean out a lot of stress, and you can find out subtle points which are there, which will come up. And that is where you need to bring about a change. If they like something, concentrate on that. If they dislike something, concentrate on that. And make an addition, make an subtraction, do a maths. Like this is what okay, you like dancing, so why not get into dancing? And that would be a hobby which you can do. And that will help you to burn your calories also, rather than like, no, go and do gym. That is something which would not work for her. So these are little things that we can work on when we are considering a patient. Thank you.
Thank you so much, sir. Do we have any other questions? Okay, so with this note, we will wind up the session. Thank you so much for your wonderful talk, and looking forward for more such talks in the future. Thank you for joining us. And with this note, we will end the session.
Thank you so much. Thank you, everyone.
So see you again in the next session, which will be announced shortly. Thank you so much.
Bye-bye.
Wishing all the Muslims Eid Mubarak. Next
Thank you.
weekend, I think.
Overall,
Yes, next week.
we celebrate a lot of functions, like celebrations over the yesterday and today. So there's Vishu for the South Indians,
Yes.
Baisakhi